So let's start with a new topic. So this is the small intestine and the large intestine, right? So we are in the GIS block, gastrointestinal system. So for this gastrointestinal system, you already finished up with the we call it GIT. Over here we call it GIT, gastrointestinal tract. So tract starts with the
oral cavity,
mouth or oral cavity and finish at anus. Anus, right? We call it anus. Starting with the oral cavity and ends in the anus.
yes,
So this is single tube, mind this. It's a single tube from oral cavity to the anus. It finish at anus. So this is a single tube. Remember this thing. This tube gets, somewhere it gets elongated, somewhere it gets narrow, somewhere it becomes some shape, somewhere it's a tube. So it makes coils and everything. So you did with the esophagus, finish, right? You did the oral cavity, then you finish the esophagus, right? And then after esophagus, what you did the stomach. Over here you did the stomach. Then after finishing of the stomach, we have the topic for the day. After the stomach, we have the small intestine and the large intestine. So what are the objectives? Differentiate the parts of the small and large intestine. So we should know what are the parts of the small and the large intestine. Then know the abdominal region or the quadrants. They are normally present. So we must know where these structures they are present. Why we want to know the structure where it is present precisely, where it is present. Why? Yes, if somebody comes and he says, I have pain here. So we should know that which structure from the small or large intestine is present here. So we can understand. If the patient says, I have a pain here, then we will be able to know if we know the abdominal region or quadrant where they are present. Right? So this is very important objective. Describe their peritoneal relation. So as I told you, why we need to know the peritoneal relation? But why? I know that.
to know if it's moved or not.
Yes, if it is a movable or rather relatively fixed organ. Mostly they are not fixed, but relatively fixed organ or they are movable organs. So if we know that this mesentery, this is peritoneal relation, so we can understand. Know the blood supply. We should know the blood supply. So because in many cases in surgery we have to remove. Yes. We have to take it out, take the part of the small or large intestine out. At that time, we should know the blood supply. Find out the clinical relevance of each part. Then we should know what will be come in the clinic from this particular region. So every time, whenever we do the anatomy, we should know the applied anatomy or the clinical relevance. So these are the objectives we will try to achieve from today's lecture. So the small intestine, these are the parts of the small intestine and these are the parts of the large intestine. So these are the parts which are related to the small intestine. They are duodenum is the first part, then we have the jejunum and the ileum. Three parts are there. What are these three parts? Duodenum, jejunum and ileum. This is the first part is duodenum. Then after this, after the duodenum, this is the duodenum. And then after the duodenum we have a junction over here which is called as duodeno-jejunal junction. Duodeno-jejunal junction. And then this blue color is showing the jejunum and then we have a part is ileum. So these are the parts. You should know the names. What are the names? Duodenum. These are the small intestine, part of the small intestine. Then we have the large intestine. So this is altogether, how much is the length of this?
6 meters.
6 meter, around 5 to 6 meter. Different from person to person, but it is from 5 to 6 meter. So meters, I'm saying, it's a long, right? From, if I ask you how much from this one, how much? This one?
10 meters.
No, let's say this is 1.
2, 3, 4, 5, 6.
So up to here. See? Small intestine. That's why I'm saying to count it from here. 6 meter in saying doesn't look like this. No, right? So this is
1, 2, 3, 4, 5, 6.
see here. It comes from here to here.
This rank in adult just or in child also?
In child as well.
In child,
Means maybe in child also. It is 5 to 6. It's not always 6. 5 to 6. It develops. Length develops. Maybe some short, some small, but it is there.
Around
Yeah. So keep this thing in your mind. Large intestine is starting from a junction called as ileocecal junction. This is cecum. This is cecum. The pouch, the blind pouch over here, you can see over here is cecum. Then we have, this one is
appendix,
colon.
colon,
Colon.
ascending one.
I will do the appendix is over here. The appendix is here coming out of the cecum. The part, it's a cecum, the out pouch of the cecum or the appendix of the appendages. Means it is hanging from the cecum. So appendix, cecum, then what is this?
Ascending colon.
Ascending colon, then this,
Transverse.
then this, then we have
Sigmoid.
an S-shaped sigmoid colon. S-shape. Actually, we will see it will be an S-shape, so it is called a sigmoid colon. Then rectum. Rectum means straight,
Yes.
right? And then we have the anal canal.
Yes.
Victor,
Right.
where is the sigmoid?
Sigmoid, we have to remove this thing.
Okay.
Then so you just remember the part over here. We have
appendix.
Appendix.
cecum, cecum, right?
Okay.
Now you can see over here, and just take me, right?
Okay.
So this starts from here. So what is there?
Cecum.
Cecum. And from the cecum, we have a hanging structure called as appendix.
Appendix.
And then this will go,
Ascending colon.
Sigmoid.
and there will be an S because of the curve of the pelvis. Right? So it will be sigmoid colon. Then after the sigmoid colon, we will be having rectum. Then rectum will be followed by anal canal. It will be anal canal. The opening is called as anus. Okay? The opening itself is called as anus, otherwise it's a canal.
Okay.
Right? So, over here I would like to take the opportunity to talk about the embryological origin of, okay, wait. It will make you confused, so I don't want to make you confused. Now, starting with the duodenum, the first part of the small intestine. We'll do the small intestine first. In the small intestine, the very first part is called as the duodenum, right? The duodenum is a very important part of the GIT, of gastrointestinal tract. So it is 25 centimeters in its length, joints. What it does? What is the structure over here? Stomach. And what is structure here? Jejunum. Right? So it joins the stomach to the jejunum. It joins the stomach to the jejunum. Then it is a C shape. It makes a C shape around the head of the pancreas. What is this? Pancreas. So it makes a C shape around the head of the pancreas. Makes C around the across around the pancreas. Begins at the pylorus at L1. You can see the L1 vertebra. So pylorus is the last part of the stomach. So ends at the duodenal-jejunal junction. Ends where? At the duodenal-jejunal junction. It's a retroperitoneal structure. So relatively fixed. But except the first part is not very retroperitoneal. It is extraperitoneal or mesentery is there actually.
Doctor, what is the retroperitoneal? Which one?
Whole duodenum.
All duodenum? Okay.
We are talking about the duodenum. Okay?
Doctor, except the first part.
Forget about it. It's not here, so you don't need to memorize. We'll talk in, if we have lab, we will talk there.
Okay.
So, receive the opening of the bile and pancreatic duct, names hepatopancreatic duct, which receives the opening of the pancreatic and hepatic duct. Juices from the liver and the pancreas. We'll go. Now, the parts of the duodenum. The duodenum have 4 parts. This one is going up. You see, starting from here and going up. So it is called as first part, and name is ascending part. The superior or ascending part. Superior or ascending part. I forgot to write ascending, but it's okay. It's superior or ascending part. Then going down. So this is descending part or the second part. Second part of the descending part. This is 5 centimeters, this is 7.5 centimeters. And then it is going towards the opposite direction, crossing the midline. So it is third part and it is called as horizontal part. It's a horizontal part. Then again, it goes a little bit up. It is L3, it goes to L2. So it is again, fourth part is ascending part. Right? So what are the levels of this? From L2 to L3. So from L3 to L2 it goes. So all the levels are there. You can just imagine this picture or make this picture by yourself, by the hands, so it will memorize it. The first part of the duodenum, now we'll move to the first part of the duodenum. Starting from the pylorus, we know that, and goes upward, backward to the first lumbar vertebra. Up to the first lumbar vertebra it goes to the first lumbar vertebra. And then its relationship. Anteriorly it is removed. We remove what structure is here? Liver. So liver, we removed quadrate lobe of the liver and the gallbladder. Because the liver is there, so gallbladder will also be there. Posteriorly, what structures you can see? Lesser sac, first inch over here. And then we have gastrointestinal, gastroduodenal artery. You can see in the lab. Look, I am explaining you, but you have to see in the lab. Must not forget to see all these relationships in the lab. Find out by yourself. If the teacher asks, shows you, it's okay. But otherwise, you have to find out by yourself. It will memorize you very much. Otherwise, it will not. Bile duct will be there. It's a bile duct over here. A bile means from the liver. A duct from the liver is called as bile duct. Right? A duct from the pancreas, it will be called as pancreatic duct. So if I call hepatopancreatic duct, means the both. The duct which is formed by the union of bile duct and splenic duct. Pancreatic duct, sorry. Pancreatic duct. Right? So it will be called as hepatopancreatic duct. So superiorly, in people like foramen, you can see in the cadaver. Head of the pancreas, over here is the pancreas, so head of the pancreas inferiorly. So here we see, this is the pancreas, right? So superior part is here. So head of the pancreas is inferior relation to the first part. In the inferior relation of the first part. So inferior is the head of the pancreas. So now we move to the second part. Second part is going downward. We knew that from the L1 to L2 to L3. So anterior relations, it's anterior relation. Now you can see over here, this is the second part. So anteriorly, it is related with the gallbladder. Why we are doing all these relationships?
To be specific.
Surgery.
Yes, surgery. Another thing is
Position of the vein.
Ligation.
one minute.
There's this
Pain, stone,
Ligation for arteries.
huh? Trauma. Very good.
Metastasis of cancer.
Cancer. Very good. Anything that happens to the
Relation.
esophagus, it can cause any. So okay, anywhere it can go. So that's why we know we are doing the relations. At least you should have a rough idea in your mind that what structures are close. Like gallbladder is very close. Inferior vena cava is very close. The pancreas is very close. The head of the pancreas, either it is inferior, superior, whatsoever. Bile duct is there. So some cancers occurs in bile duct, obstruction of the bile duct. Yarpan, you know maybe.
Jaundice.
No?
Jaundice.
Jaundice. Right? So if anything, if something happens here, something in liver, if something is liver, it can cause here also. So very close structures, those are very close. That's why we try to identify the relationship. So these are the importance of relationship. Look, the laterally ascending colon, laterally right colic flexure. When the ascending colon goes over here, and then right colic flexure, and all these are medially head of the pancreas. Again, the medial side, there is a head of the pancreas. And these structures, these relations are important for the MCQs also. Okay, short essay they can ask you. Give an account of relationship, medial relationship of the third part of the esophagus. They may ask you. So, for these reasons, you must know for the exam purpose as well as for your practice, future practice, future doctor, right? Yes. So both these things. So pancreatic duct is there, and the main bile duct and the main pancreatic duct, they all are medially because they medially, and this part of the duodenum, the descending part, is very important because there is an important structure, maybe here.
Vagus nerve.
Okay, the third part. We'll do it later on. I have a slide. I think, yeah, here it is. These are the openings of the duodenum. The openings in the duodenum are, you see, this is which part? The second part. The second part, the descending part, or the second part of the descending part. I said that this is coming from bile duct,
Yes.
from the liver.
Yes.
This is from the liver is the bile duct, or we call it common bile duct.
Okay.
CBD. In clinics they call it CBD. Okay?
Okay.
Common bile duct. It is common bile duct because there will be left and right bile hepatic ducts. They will join together. You will study. Forget about it. So this is what?
Bile duct, common bile duct.
Common bile duct. And then there will be
Pancreas.
pancreatic duct. As I told you, these will become hepatopancreatic
Duct.
duct. And they open in the second part of the duodenum as a major duodenal papilla. It is called as major duodenal papilla. This area will be called as major duodenal papilla, big duodenal papilla. And it is surrounded by structure
Sphincter.
called as
Sphincter of
sphincter.
Oddi.
When we do like this, means sphincter is there. This sphincter is called as a sphincter of Oddi or Oddi. The sphincter of Oddi, where this portion, it doesn't allow. It doesn't allow all the time, but means the sphincter is there. What this sphincter is called as? a name
Okay.
scientist was Odie.
Odie.
The scientist was Odie.
Okay.
So maybe in future it will be called a Fatima. Sphincter of Fatima, somebody else can, or if somebody can find it. So this is sphincter of Odie, and here is some dilation in this papilla, major duodenal papilla. There is a dilation. This dilation is called as ampulla of water.
Dilation?
It's called as ampulla of water, right?
Dilation in where, doctor?
In the hepatopancreatic duct.
Okay.
And before it opening, it makes a swelling over there. So that swelling is called as ampulla of water. Or this, when you see in the third part of the duodenum an opening, which will be called as the major duodenal papilla. Okay? So major duodenal papilla, ampulla of water, it is same thing. And then they have what?
Sphincter of Odie.
Do this, so you will not forget.
Okay.
Right?
Yes.
So this is the sphincter.
Sphincter, yeah.
Right? This is the sphincter.
It's a bit the minor one.
Okay, coming.
Okay.
Don't jump. So we know that maybe you did not do the rheology of the pancreas.
Yes.
Two buds are there. So two buds come, join together over here, and they have different origin. So they have different ducts as well. So there will be another part which will be called as the accessory part of the pancreas, that will be having accessory duct in few persons, in some persons. If it is there, it will be a minor duodenal papilla. Over here, it will be open separately. So it will be a minor duodenal papilla. So if you see why we are doing all these things, if you go endoscopically, and you find two things, so don't get confused. Don't worry. Just say yes, it's a normal thing. It's a duodenal papilla, major and minor.
Okay.
And in some patients, you will not see. You will see only one papilla or one sphincter of Odie. It will be doing all the time. When you will be seeing in endoscopically or your camera,
Yes.
right? So what it will be doing? So one sphincter will be only there,
Yeah.
right? So it will be sphincter of Odie. If second papilla you see, so don't get confused that this is a diseased
Okay.
or something. So it's a normal thing.
So, doctor,
And
What?
some patients, not always with everybody.
What the point of the sphincter of Odie? What the point of the sphincter of Odie?
Very good
Some
question.
pancreatic
Very good
secretion.
question. Yeah, What?
Pancreatic secretion.
it
To the
controls the secretion. What is the sphincter? What does it mean by sphincter?
Wow.
Look into my.
It's like a contraction.
Means it does not allow all the time. It opens when requires. So that's why I'm keep on making voice to make myself crazy, but it is a
No, it's okay.
point to ponder, right? Yeah, I want you to learn this. This is very good question. So the third part is horizontal. So this is the horizontal part. It is at the L3. At the L3 level, it crosses the midline, following the lower margin of the pancreas, along with the lower margin of the pancreas. So superiorly, it will be related with the head of the pancreas, anteriorly mesentery of the small intestine. So there will be a mesentery of the small intestine will be anterior, and there are vessels coming over here. Look, these vessels are here.
where is it?
These vessels, this is superior mesenteric vessel,
Okay.
and superior mesenteric vein is here. So both coils of the jejunum will be here. So anteriorly, these will be there. So what happened
Doctor,
when I was
SMA was
SMA, superior mesenteric artery. Superior mesenteric artery and superior mesenteric vein. You will find. See these structure in lab, please.
no.
Ciao.
Okay? Try to see. If I will be with you, I will show you. Otherwise,
شفناها. with Dr. Hazan.
Dr. Hazel, ask him not to give you
We see it.
lecture, just see it. With you, with yourself, by yourself, and discuss with each other. Don't discuss with Dr. Hazel. Discuss with each other. So it can give you a better knowledge and the memory. Posteriorly, right ureter from the kidney and the right psoas muscle. There is a muscle called as psoas muscle. And inferior vena cava and aorta. Both are there in the, you can see, these are the inferior vena cava and aorta. So these are in the posterior relation. So very important over here also, right? Inferior coils of the duodenum, and we said that the superiorly it will be the
Head.
head of the penis. Moving forward, fourth part runs upward. So this part runs upward. And this is the, what is this?
Inferior vena cava.
Huh?
Inferior vena cava.
What is written? No, this is inferior vena
Okay.
cava. What is this? No, portal vein is not here.
Celiac.
Portal vein will be back side of this. What is portal vein, you know? Okay, and this is not the topic of today. Jejunum forms the acute angle. Okay, now it goes, no, forget it. Don't, forget it. No, forget it. Today, forget it, because this is the part which we are talking about. So this crosses the midline, okay, runs upward along the left side of the aorta. So along the left side of the aorta, it runs like this. So this is aorta, this is right side, this is left side. So this goes around the left side of the aorta. It runs upward and then anterior to the jejunum and forms an acute angle. Then it forms an acute angle. Acute angle means less than 90 degrees. Like this. It goes and forms an acute angle. So there is no sphincter between them.
No sphincter?
Okay, no sphincter. But the acute angle makes a physiological sphincter. It's not, yeah. This acute angle is formed. And there are few ligament of teres. The ligament of teres. You see, this ligament of teres hangs over here. So it do not go down and making this angle all the time possible to give it a sphincteric action. But it is not a true sphincter. Relationship. Teres, ligament of teres, as I showed you, and then prevents from the moving inferiorly. So it gives a fixation, rather, and also it allows the make a sphincter, physiological sphincter as well. Anteriorly, relationship, roots of the mesentery and the coils of the jejunum. Posteriorly, the margins of the aorta, medial border of the psoas muscle. So there is a muscle, psoas muscle, which is not shown over here. So major important thing is aorta.
Doctor, what's the meaning? What's this?
Psoas muscle, psoas. Don't pronounce P.
Okay.
Forget about the P.
Okay.
Psoas muscle. Left psoas means left psoas muscle. We did the opening. Now, duodenal ulcers are very common. An ulcer of the first inch of the part may perforate into the greater sac, and the fluid may go to the right iliac fossa. So, the first part is very common. Ulcer of the first part is very common, right? First part of the first inch of the duodenum. In the first part, the first inch of the duodenum, the ulceration is very common over there. Why?
Why?
Hmm? No, why it is, I'm saying, very good. The acid from the stomach.
Yes.
Of course, there are some cells which are producing, neutralizing the, it is neutralizing the small intestine. The small intestine produced by itself. There are some cells which are producing the bicarbonate and means the basic effects, and they neutralize, try to neutralize, but still the first part, the first inch of the first part is very commonly suffer with ulceration. And if it perforates, then the fluid comes out, and where it goes, From the lesser sac, it goes here and produce pain here. Ulcer is here and the pain is iliac fossa.
Okay.
Okay, you got this point?
Perforate means
There is no-
Perforate means making
person.
hole in that. Perforation means making hole in that. Perforate into greater sac, and fluid may go to the right iliac fossa. The fluid may go to the, not always, but it may go to the right iliac fossa. The patient is coming with the pain over here, so we will get confused with the appendix. So,
Yes.
right? So we have to make a differential diagnosis over here also. Duodenal recess close to the duodenojejunal junction. There may be 4 small pouches, pocket-like structures of peritoneum called as the superior duodenal, inferior duodenal, paraduodenal, and a retroduodenal recess. Where it is? These recesses are at the close to the duodenojejunal junction, right? So 4 pouches are there. So there may be infection over there. Important duodenal relationship, gallbladder and may ulcerate from the duodenum. So gallbladder is very close to the second part of the duodenum. We know that, so this is very important. Jejunum, now we move to the, after the duodenum, we move to the jejunum. The jejunum and the ileum measures about 6 meters, as I told you, and I showed you also. The upper 2/5 of the length, of the total length, means 6 meters, makes the jejunum. The jejunum begins in the duodenojejunal junction, begins from the duodenojejunal junction and ends at some point which is iliojejunal junction, but it is not very well demarcated. They are not very well demarcated. We cannot easily find out that this is the jejunum and jejunum, but few separate things are there. So I will tell you in the end. And this has a mesentery which is very small. The small intestine, jejunum and ileum, has a mesentery. What does it mean by mesentery? I told you.
It's moved.
It is movable. This is what I told you is. Remember?
Yeah.
The practical I told you. What is this? Retroperitoneum. This is intraperitoneum, means I will covered by, completely covered with the peritoneum. And what is this? Now I can move here, I can move here. So mesentery. Mesentery is something attached to the posterior abdominal wall, and there's a big strain. So big gap between the structure and the posterior abdominal wall. So it can move here and there. So we call it mesentery. And everywhere it has a name. Small mesentery. Mesentery of the small intestine. So this is the mesentery of the small intestine. It is attached with the posterior abdominal wall, but the length is very big, so we can move the small intestine. During the laparotomy, you can take out all the and be spread on the table. So because of the mesentery. In living, the jejunum can be distinguished by ileum by the following. In living, we can say that this is above and this is below. So the left side of the transverse mesocolon, and upper part below the left side of the transverse mesocolon, and the ileum lies in the lower part of the pelvis. So here is the ileum. That's the living object, but in cadavers you cannot find.
Doctor, where is the mesocolon?
This one is the mesocolon. This one. Mesentery of the small intestine. Mesocolon, forget about it. We are not yet in the large intestine. I thought maybe you are asking about the mesentery. Mesocolon, forget it. Right? Just now, mesentery of the small intestine. Now, jejunal mesentery is attached to the posterior. All the mesentery are attached to the posterior abdominal wall. You should remember this. Every mesentery. All the mesenteries are attached to the posterior abdominal wall. The ileal mesentery is also attached to the below and right of the aorta. So here, so 2 mesenteries are there. So one is on the below and one is above. So above is the jejunal and this is the ileal mesentery. So attachment of the mesenteries are here. We move to the few more topics. So this is the difference between the jejunum and ileum. So vasa recta is straight arteries. You can see straight arteries is smaller over here in case of ileum, and the straight artery is longer in case of jejunum. In jejunum, the vasa recta, we call it vasa recta. Vasa means vessel. Recta means straight. Straight vessel is called as vasa recta. Right? So vasa recta in jejunum is longer. That's it. Forget about the other. Forget about the other. Vasa recta in jejunum is longer. That's it. Forget about the other. And these are called as arcuate arteries. Arcade. They are making arc like a structure. That's why they call it arcade arteries. So arcade are only one arcade here. So the other will be having more arcade arteries. So one is having arcade, vasa recta long and single arcade. That's it. The other will be opposite. Now the blood supply, the arterial supply, actually, you know, our GIT is having the formed by the foregut, midgut and hindgut. Midgut is forward.
Yes.
Foregut and hindgut are on the side. So this is the development. But what happens, just remember that up to the 2/3 of the first 2/3 of the transverse colon, up to the 2/3, right 2/3 of the transverse colon. Or if you cannot remember, just remember half of the transverse colon. It's one blood supply. After that, another blood supply up to the anus. You got the point?
Yes. No, I don't.
No.
Half of the transverse colon. Half of the transverse colon
Okay.
will be supplied by one artery. From mouth till the half of the transverse colon will be supplied by
One art.
one artery, means some artery. And from here onward, from half of the
Another.
left half of the transverse colon till the anus will be supplied by another artery.
Okay.
So there,
And in half?
yes. So arterial supply is from branches of the superior mesenteric artery. So now what we are doing? We are doing the, which we are doing now? Small intestine, right? Duodenum and jejunum. So duodenum and jejunum, what's time? I'm getting late. Isn't it? Huh?
10.
20 minutes. Okay, so I have to go fast. 10 minutes I have to finish the lecture. So this is the superior mesenteric artery, which is a branch from the abdominal aorta. So superior mesenteric artery is supplying the jejunum and ileum, both. So they give the inferior pancreaticoduodenal, middle colic and right colic. Where is the left colic? Left colic, colic means colon. Colon means large intestine. So we are not yet over here, we are giving inferior pancreaticoduodenal. So this is the inferior pancreaticoduodenal somewhere here, this one. Inferior pancreaticoduodenal, this one. And this is the right colic, a middle colic, and this is the right colic, and this is the inferior colic artery. So these are the arteries, are the branches. Inferior colic artery will give anterior and posterior cecal arteries, and posterior cecal artery will give the branch which is called as appendicular artery. So I told you all these are on the right side. Right side is coming from where? Superior mesenteric artery. This is superior mesenteric artery. This is supplying all the right side. Okay? All the right side. So right colic and middle colic. Left side is not from here, it is from the inferior mesenteric. Because it's, I told you, the embryological origin. Now we move to the large intestine. Okay? So large intestine starts from Cecum. Then cecum has
Appendix.
an hanger, appendix. Then
Ascending. Transverse. Descending.
Rectum and
anal canal. Right? So this slide shows like this. Right? Divides into cecum, appendix, ascending colon, descending colon, sigmoid colon, rectum, and anal canal. The cecum. What is cecum? It's an out pouch. It's an out pouch, means blind pouch. It's blind pouch. Why? Because it does not go here, it goes up. So it's a blind pouch. So this is called as, this structure is called as cecum. And here we have a connection with the ileum where we call as ileocecal junction. And it's a blind pouch, blind ended pouch, means cannot go downward, it goes upward. Situated at the right iliac fossa. Where it is situated? In the right iliac fossa. This region is called as right iliac fossa. So, situated and completely covered with the peritoneum. So, it's an intraperitoneal structure, so it can move. Cecum I'm talking about. I'm not talking about the ascending colon. Okay, the appendix is attached to the posterior medial surface. This is the most common attachment of the appendix. Most common appendix. Commonly, it is attached to the posterior medial. So, if cecum is here, right? So, posterior and towards the medial. Posterior and medial, not posterior.
Okay.
If it is posterior lateral, it is a retrocecal structure. Appendix is a retrocecal structure. Posterior means retrocecal, right? Posterior to the cecum is called as posterior cecal structure. So, appendix, it's a muscular tube of various length. It's a vestigial organ they used to suppose. Nowadays, now new theories are saying something else. It's a vestigial organ. What does it mean by vestigial organ? No fayda. Mafi fayda. Right? There is no benefit, no function, but it has a big history. I will tell you later, sometime if I have time, I'll tell you the history of appendix, or you can Google the history of appendix. So, the vestigial organ, but nowadays they said no. There are some bacteria. Produce bacteria. Bacteria. The bacteria are produced in appendix, which are very good for our flora. Yeah, down in GI flora. It's very good for us. So they are making some research and they are saying nowadays. It has a mesoappendix. Now look, mesocolon. Who asked me? Somebody asked me mesocolon, right? You asked me. When we say meso, means mesentery. Mesentery. When we say meso, it's mesentery. Right? Now we say mesoappendix. So mesentery of the appendix. When we say mesocolon, mesentery of the colon. When we say transverse mesocolon, mesentery of the transverse colon. So, where the mesentery will be attached, as I told you, rule of thumb, posterior abdominal wall. The posterior abdominal wall, it will be attached over there, somewhere at its level. So, it is attached to the posterior abdominal wall. When we say mesoappendix, so it means, what does it mean by when we say mesoappendix?
Mesentery of the appendix.
Yes, but when we say the mesoappendix, what does it mean?
when there's a layer or posterior or
Because it needs movement. So, appendix is a movable organ. So, it is not a fixed organ. So, what happens that, okay, so mesoappendix contains, and these mesentery are giving attachment, and the major important function of the mesentery, you are not supposed to cut the mesentery or do play with the mesentery any time. in your life. Why? Because it carries the neurovascular bundle. It carries along with this nerves and vessels.
Okay.
Carry and supply that particular organ. So it is not only giving the support to hang with the or pull with the posterior abdominal wall, the structures with the posterior abdominal wall, but it also supplies the vessels and the nerves. Vessels and the nerves goes through the mesentery or even the ligaments inside in the abdominal cavity. The ligaments are also very important because they also carry the neurovascular bundle, we call it.
Okay.
Means nerves, vessels, veins and arteries, even the lymphatics.
Doctor,
Yes.
you mean by mesentery is retroperitoneal organ, but it's movable?
You said before in here.
Mesentery retroperitoneal organ, but it's movable, not fixed.
It's intraperitoneal organ, not retroperitoneal.
But have attachment to the cerebral.
But
يعني هو intraperitoneal but have attachment to
look,
the
we
cerebral.
have, I have to go, I will give you the question separately, answer to this. Yeah, it needs long time and we don't have.
Okay.
So, okay, so this is the McBurney's point. This is called as McBurney's point. Appendix lies in the right iliac fossa and relation to the anterior abdominal wall base is situated 1/3 on the way to the line joining the right anterior iliac spine and the umbilicus. So this is my umbilicus and this is my right iliac spine, anterior superior iliac spine we call it. Make a line over here. So this is our anterior superior iliac spine here, right?
Yes.
And then this is umbilicus. So line joining these. So 1/3, the lateral 1/3 is the point is called as McBurney's point, and most of the time appendix lie over here.
Doctor, this is very important in clinical.
In clinical. Right? So McBurney's point, they draw, before they make the incision over here, they draw a line, which is, right? Which is, and they will ask you to make a McBurney's point. Then you make McBurney's point, so you make a incision, McBurney's incision over here. Sorry. What? Nice. So appendix, okay, how can we identify the appendix? These are, you see, these are the muscles. There are muscles in the, you did in the histology or no?
No.
The GIT. There are muscles inside are circular and the muscles on the outer side is longitudinal. Right? So what they do, they contract like this. So food can move forward in peristalsis. So they contract like this. So histologically, so what happens over here, there are a few muscles, longitudinal muscles present, 3 longitudinal muscles are present outside the colon, the large intestine. And they are called as tinea coli or tinea coli. Tinea coli, over here it is written. Tinea coli. These muscles, they are 3 muscles, one anterior, posterior and medial muscles are there. So these muscles, when they contract, so they make a bulging structure called as rostra. These are called as rostra. So I think this is not written over here, so you don't need to. So what we do, we cannot find appendix in some cases. When we do the surgery, we cannot find the appendix. So what we do, we follow these tinea. They will, from 3 sides, 1, 2, 3, they unite in one structure. In one place they unite over here. And this union will give rise to the appendix. So then you can say, oh, okay, this is appendix. Maybe you can see this on cadaver. Okay?
Okay.
Try to see it in cadaver. These tinea coli or coli, you can see it. Ascending colon is over here. This is the ascending colon, about 13 centimeters long and lies in the right quadrant, lower quadrant, right lower quadrant. Okay? It lies in the right lower quadrant on the left, on the right side. Extend upward from the cecum, inferior surface of the right lobe, and it gets turned it gets turned, right? It gets turned. So it is called as, what is this?
Liver.
Liver. So we call it which colic flexure? Right colic flexure or hepatic flexion. You can call it hepatic flexion. It is not there? It is not there?
Another photo.
Okay, because of the animation, yeah, I'm sorry. I will upload it. I will upload, don't worry. I will upload. I'll go and I will upload the PowerPoint presentation. Yeah. So this is called as right colic flexure. What it is called as? Right colic. Colic what? Colic flexure or hepatic flexure. Don't say right hepatic flexure. Or you can say right hepatic flexure. Right? Hepatic flexure or right hepatic flexure means the turn, the angle. The peritoneum covers in front, so it is a retroperitoneal structure. So relatively not movable. Transverse colon, you see, this is the transverse colon. So where is the transverse colon, by the way?
In the middle?
Hand on your tummy.
In the front of the second part.
Yeah, this is wrong. Wrong. Umbilicus. Yes.
But
That's what I
the
asked you
stomach
to.
is it's
Yes, the stomach is here.
have the transfer
Right.
colon.
So it is transverse colon. That's why I asked you to put your hand on your tummies. Transverse colon is about 3 centimeters and extend across the abdomen, occupying the umbilical region. The umbilical region. Okay, occupying the umbilical region. Don't go far.
Where's
Up.
my stomach? Here?
Your stomach is here.
طب how the transfer colon?
Huh? What?
How my transfer colon is here or my stomach here?
So transverse
It's-
colon is below
it's
the
bit
stomach
of the
and below
stomach.
the stomach.
Yeah.
Yeah.
But it's
Again, we have the mesentery. Look, there will be another picture. We have the right colic flexure, then it is starting from the left right colic flexure to left colic flexure. This is called as transverse colon. So right colic flexure to left colic flexure, the area between them is called as the transverse colon, and it is 38 centimeters in length and finish at the right colic flexure, transverse, and it has a transverse mesocolon, as I told you. So what is the reason? Because of the transverse, this is called as the transverse mesocolon. Over here, you can see transverse mesocolon, pancreas, and this is going to the posterior abdominal wall. So it is transverse mesocolon. So now you can see in this diagram that sometime the colon, this transverse colon, as I told you in the lab also, sometimes it comes in the pelvic cavity because of the mesentery, large mesentery. Extremely variable and may sometime reaches down as into the pelvic cavity. The blood supply, now tell me the blood supply. The 1/3 or the half of the, it will be supplied by
Superior mesenteric.
superior branches from the superior mesentery.
Yes.
That is right side, so right colic artery, middle colic artery, and that's it. The branches from the, and this will be supplied by the inferior mesenteric. The whole of the rest of the proximal 2/3, as I told you, the proximal 2/3, not the half. The proximal 2/3 means the first 2/3 of the transverse colon will be supplied by the branches from the superior mesenteric, and the rest, distal 1/3, will be supplied by the branches from the inferior mesenteric. So veins, vice versa, right? So the proximal 2/3 will go to the superior mesenteric vein, and the distal 1/3 will go to the
Inferior mesenteric
vein.
So Dr. Jejunum and ileum supplied by what?
No, come on, who said this?
Me.
Yes, yes, very good, very good. Make it clear over here. Jejunum is from where? Jejunum and ileum is from where?
Both
It's,
sides.
I said whole GIT up to the transverse mesocolon. So it is before.
Doctor, 2/3 colon middle colic artery, superior mesenteric artery, with 1/3 they come from left colic artery.
Wait. The left colic artery is a branch of inferior mesenteric.
Oh, okay.
The descending colon is 25 centimeters and it extends from left colic flexure. So this is the left colic flexure. It comes to the sigmoid colon, where it becomes continue as sigmoid colon. So it continues as sigmoid colon. Now you can see this S,
Yes.
right? So this is sigmoid colon. Then it will go as a rectum. The peritoneum covers in front, so it is a retroperitoneal structure. The blood supply is the inferior mesenteric, branches from the inferior mesenteric, that is the major branch of the inferior mesenteric is the left colic. Right colic and middle colic are the branches of?
Inferior mesenteric.
This may be the MCQ, okay? And the inferior mesenteric, left colic is a branch of what? It can be like this, that there should be a story, okay? It will not be direct question. Mind
Case
this.
scenario.
Yes, case scenario. Or maybe not the case scenario exactly. They may ask that, you know, that embryologically it is different origin in this, and then finally they will ask a question.
So Dr. Jejunum and ileum supplied by both arteries because they are both sides.